Hello again, and welcome back to the Oncology Brothers podcast. I'm Rohit Gosain, and here with my brother and co host Rahul Gosain. In our ongoing series of treatment algorithms, more recently we have been focusing on hematological malignancies. And today we'll be talking about CML, chronic myeloid leukemia.
But thankfully, CML still remains a rare cancer. We're talking roughly about 9 to 10,000 new cases a year in the US. TKIs have changed the natural course of this disease. Thankfully, our patients are living longer. So that means that though the incidence is still low, the prevalence of CML has increased. Since the last year, we've seen a few new changes. Now, Asciminib is approved. We've also seen some safety updates with Ponatinib. Dose optimization has been a hot topic all around. So we have a lot to cover from the workup to treatment options. And for this, we're excited to welcome back Dr. Jorge Cortes from the Georgia Cancer Center. Jorge, thank you so much for joining us.
Thank you for having me.
Jorge, welcome back. As Rahul mentioned, we've seen few changes over the last year in the field of CML, and you have been involved in almost all these studies. Before we talk about the data and the treatment options available, let's start off with your workup for CML. In a patients where you have leukocytosis, neutrophilia, and after ruling out secondary causes, CML is being suspected, and FISH study has revealed concerns of CML. Do you get a bone marrow biopsy on all your patients up front, cytogenetics? What does it look like before you start talking about treatment options?
That's a great point. I'm glad you bring it up because I do see more and more patients that are being diagnosed and treated without a bone marrow. I still think that a patient needs a bone marrow. It is part of the recommendations by ELN, by NCCN. Personally, I think there is value on that. For one, you want to know if the patient has fibrosis, which may alter some of the responses, side effects that you see in the patient's myelosuppression and so on. You need the cytogenetics. The presence of additional chromosomal abnormalities has an impact in prognosis. And you want to know if they were there at the start. And if things don't go well, if you find them, were they there or they just appeared? That makes a difference. Even the differential, there's sometimes some mismatch between what you see in the peripheral blood and in the bone marrow. So it gives you a better idea for the staging and all of that. Now, for follow-up, we don't do bone marrows all the time, but having that baseline will classify your patient, risk classify your patient. I think it is very important.
And Jorge, so after this initial workup and bone marrow biopsy, often we're putting our patients into different buckets, chronic, accelerated phase, but then we also start to classify patients as low risk, high risk, and then consider these first or second or third generation TKIs. In all studies for these newer agents, we see that the benefit is regardless of how you risk stratify these patients. Today in your clinic, how do you decide who gets upfront Asciminib versus Imatinib, or let's say Ponatinib, Dasatinib? How do you decide between these available options moving forward?
Yeah, I fully agree with you that the studies have shown that even in the low risk, you see benefit with the new generation. When we were comparing Imatinib to the second generation, benefit with the second generation. Now that we're comparing Asciminib to the other ones, we see benefit with Asciminib. Of course, in the high risk, there's more need for that improvement, but even a low risk patient deserves the opportunity to have a better response rate. So to me, that's not the selection criteria. I think it comes down to the goals of therapy and very importantly, to the patient's goals of therapy. Our job is to educate the patient to see pros and cons of the drugs on the probability of achieving, for example, a deep molecular response, possible side effects that you see with one or the other, how that matches with, for example, their comorbidities, with the other medications that they're taking, put it into perspective and see what works best for the patient. That is to me what makes a difference. If the patient says, I really want to go for what gives me the best chance to stop therapy, okay, well, that gives me some suggestion. Maybe I'll go with Asciminib first because that probably has the best response. If it's somebody that says, I want whatever gives me the lowest probability of getting a heart attack because I've already had one, I have diabetes, I have hypertension. Well, Imatinib, and let's not forget, Imatinib is a good drug. There's nothing wrong with Imatinib. As I said, our job is to educate the patient of what we can expect with each drug and the benefits of getting to a deep response versus not, and things like that.
I think this is something that we mention in every podcast, that patient-shared decision-making
Yep.
is the key aspect of everything that we treat, whether that's hematological malignancies or solid tumors. And as you stated, Jorge, with Imatinib, one has longer follow-up, less cardiovascular toxicity, but with these newer agents, one gets faster and deeper responses, but that does come at the cost of financial toxicity, which is certainly a concern, and some unique side effects, which we will dive into shortly. Jorge, when it comes to monitoring for response, is BCR-ABL titer good enough? And as you stated that you do get bone marrow biopsy initially, but any role, not for follow-up, but at the time of progression?
Yes, definitely. Nowadays, we mostly do it by PCR. At the time of diagnosis, you want cytogenetics and PCR, both of them. And I actually also do FISH because you want to see that they do have the Philadelphia chromosome. You also want to see that your typical PCR captures the transcripts. Some of the commercially available PCRs don't detect the atypical transcripts. They're not common, but they can throw you a curveball if you didn't know that they were not detectable. You may think very quickly that your patient has a great response with an undetectable transcript, but it's undetectable because it's atypical. If you see a patient that has a Philadelphia chromosome, but it's PCR negative, then you can talk to your lab and say, can you determine if it is an atypical transcript? Those atypical transcripts, most labs, most commercial labs, and even academic labs cannot quantitate by, for MMR and that kind of thing. So you know that you're not going to quantify them that way. Your FISH is going to be your most sensitive way to quantitate the response. Not as powerful as a PCR, but in that setting becomes the best. Now, for those are not common. They're probably 2-3% of the patients, but when they come to you, you need to know. Once you know that you do have something that's detectable and quantifiable and can be measured by the international scale, then yes, you can follow by PCR. It grossly matches the cytogenetic response. So you know that when you get to below 1%, you're about complete cytogenetic response. And then we have these major molecular responses and so on. Usually what I do is first year, about 1 year every 3 months. After the patient gets a major molecular response, I go to every 6 months.
Mhm.
I don't recommend doing more frequent than that because there's variability in the test. And if you do it too frequent, it becomes sometimes confusing, sometimes even stressful for the patient when they see small changes. And at the higher numbers, there's more variability. So I think every 3 months is good enough.
All right, thanks for touching on that. When we're talking about monitoring, can we also touch on the role of MRD? First, how are you defining MRD? Second, is 2 years the right time? Should it be 5 years? And then lastly, out of the available options, which one is giving us the best benefit when we're looking at this?
There's been a bit of a controversy here. We talk about deep molecular response. That's why we put it on the guidelines and stuff like that. There's a little bit of discrepancy. There's some that say MR4, so 0.01 or less, and some MR4.5, 0.0032 or less. And both are great responses, but especially when talking about stopping therapy, I abide more by the MR4.5. There's some studies have used one, some studies have used the other one. Certainly, if you use MR4, you have more patients where you can stop therapy, but also more patients who relapse. They want to stop therapy and stay off therapy. So I
Absolutely.
want to select my patients better. Now, the second point is what you mentioned, the duration. Is it 2 years? Is it 5 years? The minimum to me is 2 years. Again, there's been studies doing 1 year, but you see more relapses. To me, it's minimum 2 years. But I always tell the patients that when you go to 5 years of sustained MR4.5, the chances of you staying without therapy increase. Now, some patients, maybe they already have enough side effects that they say, gee, I really want to stop. That's fine. 2 years is good enough. But about half of the patients will relapse. So another one of these areas that you need to talk to the patient to see what's important to you. Can you continue for a little longer? There's no right or wrong answer. Telling them the benefits and disadvantages of each and see how it works. Now, importantly, if you're going to stop, we need to monitor the patients every month. When possible, I do it every month. For some patients, it's very difficult. They live far away. There's people who come from a distance and so on. I think 2 months is good enough. I don't want to go farther than that, but I do it every month. But I think 2 months is reasonable. I wouldn't discourage a patient from stopping therapy if they are good candidates just because I cannot follow them every month.
I think this is a good segue to touch on. Often, when we're switching from one TKI to another, it's either because of the tolerability or the disease is progressing or relapsing. Jorge, is this a good time to look for NGS and these resistant mutations if we're worried about progressive disease or poor tolerability on their current TKIs?
I think so, particularly if the first TKI is because of resistance. If it's intolerance, then no. If it is because of resistance, and particularly if it is resistance to a second generation TKI. So that's kind of what I do. If they've already failed one that was a second generation TKI, or two if the first one was Imatinib, I start thinking about NGS because you can't find those mutations at the time of diagnosis, but I'm still going to give them a TKI. So yeah, if you have the setting and the resources, sure you can do it. But more practical, I think when a patient has resistance to two TKIs or at least one second generation TKI, you're going to start seeing that instead of finding ASXL1 mutations in, let's say, 10, 11% of your patients, it's going to start getting a little bit higher. You start selecting those patients. I agree with you. That's a good time to check on that. And definitely, 3 TKIs, that's probably a must.
When talking about the NGS and resistant mutations, we have to keep certain mutations in mind with these TKIs, except Ponatinib, which is active in all single gene mutations, including 315I mutation. Actually, while on Ponatinib, decades ago, this is when it was approved, though it has been associated with vascular occlusive events. The data published in Blood last year, and even your efforts, Jorge, with the OPTIC study, we have seen better safety profile with dose adjustment with Ponatinib. Jorge, can you touch on where does this fit in your treatment algorithm, but also how you dose Ponatinib in your clinic?
I think that we've come a long way learning about how to use Ponatinib and probably other drugs as well. It becomes relevant in Ponatinib because of these arterial occlusive events that you mentioned. And so just a reminder that that OPTIC study, what it did is was randomizing patients to 3 different starting doses, 45, which is a standard 30 or 15. The novel thing was that when the patients responded, and here the response was 1% or less because these were heavily treated patients, they would reduce their dose to 15 milligrams. What it showed is that 45 is still the most effective dose. There was a significant difference in favor of 45. This approach of reducing the doses greatly reduced the risk of arterial occlusive events. It went down dramatically. It's even similar to starting with 30 milligrams. When we looked at the dose intensity at the end of the first year, the patients who started with 30 milligrams ended up taking more drug over the first year than the patients that started with 45 milligrams because they reduced the dose to 15 milligrams. So that's important to keep in mind. Now, the dose, so I start with 45, and it's particularly important with patients with T315I. This is interesting because even with these two drugs that we have for T315I, Ponatinib that we're talking about, dose seems to be particularly relevant for T315I because remember, Asciminib also uses a higher dose for that. These are good drugs, but dose is particularly relevant. For other patients, there's still a benefit of 45 versus 30 in patients with other mutations or with no mutations. The difference is not as large. I still go with 45 unless I really need to go easier. One thing to remember is when you have a patient that is a good patient for Ponatinib, first of all, control comorbidities. Manage diabetes, manage blood pressure, manage cholesterol, stop smoking, all these things, because the risk is a sum of risk factors, and Ponatinib is a risk factor. But if you eliminate others or control others, your risk is going to be lower. And then, very importantly, reduce the dose when you get a response. If you do that, I think the safety comes down to much, much more tolerable, and you can offer the drug to patients who need it.
Absolutely. This ends up being a good example for us out in the community. It's not only about an approval, but getting comfortable with managing the right dose and keeping our patients on this for longer. Again, reiterating for Ponatinib that dose reduction after upfront response is very important, but starting them at the right dose initially
Yeah.
is critical. Jorge, you touched on side effects even from other TKIs. Can you briefly touch on side effects to keep in mind with other TKIs? And then we'll touch on the relapse refractory disease and the role of transplant.
Well, we've known the side effects of some of these drugs for a while. Imatinib, we mentioned, it's by far the drug with the fewest cardiovascular toxicity side effects. So that's the safest for a patient with a lot of risk factors. Now you have to deal with other things. It has the muscle cramps and the periorbital edema and things like that. We know the pleural effusion with Asiminib, somewhat dose related. So lower doses seem to reduce the risk. GI toxicity with Bosutinib, some liver toxicity, Nilotinib, a lot more of the metabolic syndrome kind of things. The most common things that we see are hypertension. It is interesting. We see it with all the drugs, but in these randomized studies, it seems to be a little bit more, mostly grade 1 or grade 2, so manageable, but we need to keep an eye on that. And the other one is lipase elevation. In that randomized frontline study, the lipase elevation seems to be at about the same rate or lower than the other drugs. So it's a class effect. It's interesting because we're not used to measuring lipase regularly on patients. And then what do you do with a lipase, asymptomatic lipase elevation? And on the one hand, you hate to ignore it if it is high. On the other hand, nothing's happening to the patient. So you have to do something if you're looking at it and it is very high. And most of the elevations that we see with Asciminib or with others are asymptomatic, not clinical pancreatitis. But that's something to keep in mind in terms of the safety profile of Asciminib.
Absolutely. And again, once the disease starts to progress and relapse refractory disease, we're also looking at transplant with accelerated phase. We're often using our best TKIs upfront, like Asciminib or Ponatinib, but this is another place where we're often thinking of transplant earlier. Jorge, any final thoughts here before we close of transplant and the role of this here in CML?
Yeah, a couple of comments about what you mentioned. One is accelerated phase. Many of us have seen this. There's no accelerated phase. However, they do have a high risk chronic phase, and the definition is mostly that definition of accelerated phase. We can call it whatever, but that's a group of patients that need special attention. They're not doing well. So, however we call them is probably more semantics. They need attention. A patient that progresses to that stage, I usually would say give them change them or TKI because usually need to do some workup and whatever to get them to a transplant, but start working on the transplant. A patient who's diagnosed in accelerated phase can do well without a transplant. A patient who progresses to accelerated phase needs a transplant. The other group where I think we need to start thinking about transplant a little earlier is those patients with SXL1 mutations. One, we don't usually measure with the diagnosis. Two, there's no data that it's going to get any better. But a patient that's already gone through a couple of TKIs, and we talked about that's a good setting to check for NGS. If they have ASXL1 mutations, we know that with all the TKIs, the prognosis is poor. I think it is time to consider transplant in that patient. If they're in chronic phase, yes, but today we don't have a better answer for those patients with the available TKI. I think, of course, we know about blast phase and all of that, but this is a chronic phase indication to me relatively early.
Absolutely.
We have covered a lot here in the last few minutes, and we hope that after this discussion, our community colleagues are feeling a bit more comfortable in taking care of CML patients. Jorge, thanks so much for walking us through your treatment paradigm. For our listeners, let us go over a quick recap. In today's update with Dr. Jorge Cortes, we revisited the essentials of CML management, upfront workup and stratification with all the foundational and frontline choices, including Asciminib, along with the established TKIs, each selected for individual patient factors, and then, of course, monitoring for molecular milestones and looking for resistant mutation at the time of progression is very critical.
Another big takeaway here was how to manage some of the side effects that come along with these TKIs. Important is to recognize some of the nuances and unique side effects that are associated with these TKIs. For example, we touched on dose optimization for Ponatinib. After initial response, decreasing that dose of Ponatinib makes a world of a difference in decreasing these vascular occlusive events. Then for other TKIs, such as Dasatinib, pulmonary hypertension and pleural effusion should be on our radar. There's a lot going on in the world of CML, and partnering that right patient with the right TKI is critical. Thanks for joining us. Make sure to tune back in for other episodes around treatment algorithms, FDA approvals, and conference highlights. We are the Oncology Brothers.